All right. Hello, everybody. My name is Dr. Brian Dawson. I'm the Senior Medical Director at Ideal Option. I have with me today Dan. Dan, how about you introduce yourself?
All right, my name is Dan Goulette. I'm one of the physician assistants at Ideal Option, and I also serve as a regional provider leader for a number of our states, helping to oversee the clinical practice of our providers.
All right, perfect. Thanks, Dan, for helping out. Today, we're going to talk to you about initiating buprenorphine in the emergency department. So what we plan on covering today is, number one, what is opioid use disorder and what are the criteria to diagnose it? Number two, what is buprenorphine and maybe some of the other medications that are used to treat opioid use disorder? Some of the evidence for initiating buprenorphine in the emergency room and how to initiate and administer buprenorphine in the emergency room, and also how to refer patients for ongoing outpatient treatment once you've treated them within the emergency room. So what's opioid use disorder? Well, ASAM has a definition that defines opioid use disorder as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and the individual's life experiences. People with addiction use substances to engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And I think this is the most important point we want to address today, is that opioid use disorder is a chronic disease, and that if you manage it like other chronic diseases, you will be able to improve your chances of long-term recovery. So like we mentioned, there are other medications that we can use for the management of opioid use disorders. The three main medications that are FDA approved are methadone, which is a full opioid agonist on the opioid receptor, buprenorphine, which acts as a partial agonist at the opioid receptors and generates limited effect at those receptors, and then naltrexone, which is a full opioid antagonist and blocks those effects. So the criteria for opioid use disorder and diagnosing opioid use disorder, it is similar to the diagnosis of other substance use disorders. The categories include criteria for impaired control, social impairment, risky use, and the pharmacological properties of the substances abused themselves. So if you have up to 3 of these criteria, then you have mild opioid use disorder. 4 or 5 of these criteria, you would be diagnosed with a moderate opioid use disorder, and 6 or above would qualify as a diagnosis of severe opioid use disorder. So what is buprenorphine? We talked about the 3 approved medications for use for opioid use disorder. Buprenorphine is the partial opioid agonist that helps manage the cravings and withdrawal symptoms associated with opioid use disorder. It's available in many formulations, including sublingual films, strips, tablets, injections, and monthly implants. The most common route of administration is sublingually. The advantages of buprenorphine is that it has essentially the ceiling effect, which reduces the risk of some of the complications of full opioid agonists like methadone. It lowers the risk of misuse, addiction, drug interactions, and other side effects relative to full opioid agonists. And it lowers the risk of euphoria and some of the complications like respiratory depression relative to full opioid agonists like heroin or methadone. And buprenorphine has a long half-life, typically up to about 36 hours, which can allow for daily dosing, and in some situations, even alternate daily dosing. So what is the evidence for buprenorphine treatment in the emergency room? Recent studies have shown that the prior practice of referral to social services from the emergency room results in about a 1/3 or a 37% retention rate in treatment at 30 days. So when you study the number of patients who get referrals and you follow them 30 days after that referral, what percentage of them have followed up? And with just a simple referral, the amount of patients that follow up is relatively low. But you can see if you add a brief intervention, which could include direct referral to community treatment services, scheduling appointments, and intervening in the treatment, you improve that slightly. But the most significant improvement in a patient's engagement in treatment is if you actually initiate buprenorphine treatment in the emergency room. So if the patient receives that dose in the emergency department, their chances of following up and engaging in treatment essentially doubles up to nearly 78%. Do you have anything to add on that, Dan?
Yeah, I just want to add one thing. So the primary outcome this study looked at was engagement in treatment at 30 days after the intervention, whether that was a referral, brief intervention, or buprenorphine in the emergency department. And they defined engagement in treatment as any sort of ongoing contact with formal addiction treatment, whether in the inpatient or outpatient setting. The study also found, I don't think reported this outcome here, that the cohort who received buprenorphine had a decreased utilization of inpatient resources longitudinally.
No, and that's a great point. There are a lot of studies out there that show that patients who begin buprenorphine treatment and are engaged in outpatient management with buprenorphine have a much lower return rate to the emergency departments, much lower use of other medical services. So how do we go about initiating buprenorphine in the ER? Well, first off, we want to make sure that the patient qualifies. And so you want to make sure you have a clear diagnosis of opioid use disorder. And in particular, if we're initiating buprenorphine, the biggest risk of initiating it too soon would be putting the patient into precipitated withdrawal. Buprenorphine has a higher affinity to those opioid receptors than other opioids. So if you have other opioids in your system, and even longer acting opioids like methadone or OxyContin, and those receptors are fully activated by those other medications, adding buprenorphine will dissociate those drugs off of those receptors and can essentially precipitate withdrawal, as the buprenorphine itself does not create as much activation at those receptors as those full acting opioids. So patients who are taking long-acting opioids, you want to make sure that they're off of opioids for up to 72 hours, opioids like methadone or other long-acting full agonists. And you may want to consider consultation before starting buprenorphine in these patients. We also want to make sure that you use caution if a patient has a history of benzodiazepine, alcohol, or high-dose gabapentin use, as mixing opioids with sedatives can cause increased risk. And then again, fentanyl-dependent patients, you may have to wait longer as well. And Dan can tell you a little bit more about fentanyl.
So we're seeing an increased prevalence of fentanyl in the drug supply. Typically, it's marketed as oxycodone 30 milligrams. They're referred to as Mexes or blues, the small blue tablets. We're also seeing more fentanyl produced and marketed as counterfeit alprazolam and cut into cocaine, methamphetamine, and MDMA. So if you're seeing a patient who reports taking illicitly obtained oxycodone 30 milligrams, determining whether or not they're actually obtaining that from a known prescription or they're taking it from the street, that will sort of guide you as to whether they're actually obtaining oxycodone or fentanyl. You can also use drug testing to tease that out a little bit. For folks who are using fentanyl heavily over prolonged periods of time, there's extensive systemic distribution that can cause fentanyl to remain in the system and put the patient at risk for developing precipitated withdrawal up to 36 hours from the last use. So if you're concerned about a patient who is fentanyl dependent, you can certainly consult us as well for additional guidance.
All right, thanks, Dan. Next slide. All right, so once we've identified the types of opioids the patient has been using in the last time of use, the next step is to assess the level of withdrawal the patient is in. We typically use what's known as a COWS score, a clinical opioid withdrawal scale. And it has several categories that the patient can score or you can score as a provider. And you can assess the severity of the patient's withdrawal. Again, some patients may report higher doses of or higher symptoms of withdrawal even early after last use. Medications that are short acting, like fentanyl, can cause withdrawal symptoms even within several hours after the last use. After you've assessed the level of withdrawal, now we consider dosing. Now, if the COW score is low, it is likely that the patient has either used recently or has maybe used a long-acting opioid and is not in significant enough withdrawal to initiate buprenorphine treatment in the ER. So if the consideration is to not dose in the ER, if you have a waivered provider on staff, then you can actually provide a prescription for buprenorphine that the patient can take when at home and in withdrawal at a later time. This is typically what we will do in an outpatient setting. If a patient arrives to a clinic, has recently used opioids, but is not actively in withdrawal, you can prescribe the medication and the patient can be instructed on when to initiate it. If there's no waivered provider in the emergency room, you can arrange for a follow-up appointment for ongoing treatment in an outpatient setting. And we'll talk about that a little bit later. And when dosing in the emergency room, we typically recommend initiating an 8 milligram sublingual dose. You can divide that in half and start with 4 if there are increased concerns for precipitated withdrawal. We recommend you observe that dose in the emergency department for symptoms of withdrawal. And as long as they're in a controlled setting and the patient is comfortable, then it is safe to discharge the patient after medication dosing. Again, if you have a waivered provider, a prescription can be provided after that initial dose in the ER.
And I would just add one thing to that as well. So the COW scoring is quite effective for short-acting opiates, including heroin, oxycodone, hydrocodone. But just as a caveat, the COW score loses some of its utility in predicting or being used to predict the potential of precipitated withdrawal for folks who are taking a longer-acting opiates like methadone or fentanyl when used over a longer period of time.
No, that's a great point. Patients can experience significant withdrawal symptoms, but the initiation of buprenorphine can actually make things worse if you're doing it too soon, particularly with long-acting opioids or fentanyl. So how do we administer buprenorphine? Again, we talked about how it comes in either strips or sublingual tablets. You typically place it under the cheek, allow the patient to hold it either at the side of their cheek or under their tongue until the medication dissolves. Once the tablet or strip has dissolved, you want the saliva to remain in the mouth for up to 15 minutes while that medication is being absorbed. You want to avoid talking, eating, drinking, or smoking while the medication is being administered. So the 3-day rule for buprenorphine, the DEA, again, is aware that patients may need this medication. And so any provider, particularly emergency room providers, can administer a single day of a medication to relieve acute withdrawal symptoms for up to 3 days in a row. So if a patient presents to emergency department on a Friday evening and requires a dose of buprenorphine, a non-waivered provider can administer a single dose on that Friday. They can have the patient return to the emergency department on Saturday and Sunday up to 3 days in a row, and they can administer those doses. And that does not require a DEA waiver. If you were to prescribe a prescription for treatment as an outpatient, then you would be required to have that DEA waiver. So step 3, the patient has received their dose. The next step is to ensure a warm handoff to ongoing treatment. Ideal Option has located clinics within your area, and you can call 1-844-GO-IDEAL, and we have a 24-hour on-call service that can arrange outpatient follow-up in any of our clinics. And to find the closest clinic, you can also visit our website at www.idealoption.com. we recommend adding your local ideal option clinic information to your EMR so it can be easily included in discharge instructions. And at any time you wish to contact us here at Ideal Option, we can send your emergency department referral kits that include the information we presented today, as well as the numbers for warm handoff referral. And we hope to be able to help you in any way we can get these referrals for treatment for your patients in the ER with opioid use disorder. So thank you very much. Again, give us a call at 844-GO-IDEAL if you have any questions. And thanks to Dan for helping out today. And we were happy to bring this presentation to you.